Welcome to the Cleveland Clinic Epilepsy Grand Rounds. As you know, today we are having a webinar format, meaning our speaker is have graciously agreed to speak from his hometown. So we won't be gathering at our conference room. As you know, as this is a webinar, you will be muted, but you will be able to write your questions as we go on the chat. And at the end, if there is time allowed, you will be able to unmute and ask a question directly if time's allowed. There is a CME credit that Dr. Perez will show at the beginning and end of his presentation, but also you can follow the link that you are seeing right now on the chat. I want to introduce now our dear colleague and friend, Dr. Chris Trainer, who will introduce our speaker for today.
Yes. Welcome, everyone. So for those of you who don't know me, I'm Chris Trainer. I'm one of the staff members here in Epilepsy and one of the epilepsy educators in our fellowship group. And it's my distinct honor and pleasure to introduce our speaker today, Dr. David Perez. Dr. Perez is a board-certified neurologist, psychiatrist, and also in behavioral neurology and neuropsychiatry, and is a fellow of the AAN, the ANPA, APA, and ANA as well. He is a full-time faculty member at the Mass General Brigham Departments of Neurology and Psychiatry and an associate professor at Harvard's Medical School. He's also the chief of the Mass General Brigham Division of Behavioral Neurology and is the founding director of the Multidisciplinary Functional Neurological Disorders Unit and F&D Research Group at MGH. He has published over 100 peer-reviewed articles, the majority in the fields of functional neurologic disorders, brain imaging research, and behavioral neurology and neuropsychiatry. He has also co-edited several special issues on functional neurological disorders and a recent 32 chapter, Springer Functional Movement Disorders textbook. Dr. Perez is also affiliated with the MGH and Harvard Science and Technology Martineau Center for Biomedical Imaging, and he'll be gracing us with his expertise on F&D and how it relates to our patients in epilepsy and in all of neurology. So, Dr. Perez.
Dr. Trainer, thank you for that warm introduction. All of my friends and colleagues at the Cleveland Clinic, it's a pleasure to be here with all of you. A special thank you to Dr. Becky Tillahoon, who is someone I've had the pleasure of getting to meet in several professional societies, and now we're beginning to exchange intellectually, and it's very exciting. Let me go ahead and share my screen here. Just give me one moment. And maybe I can just get confirmation that you can see my slides. Dr.
Yes,
Trainer.
Yeah, we can.
Okay, excellent. So I have an ambitious agenda today, and I'm also looking forward to a bit of a conversation towards the end. But today's topic is the neuropsychiatric, neurology meets psychiatry meets rehabilitation, approach to functional seizures and functional motor disorder. I'm going to take quite a bit of a broad approach, and you'll see that. Here is the CME credit. I'll linger here for a moment so you can get the QR code, and I'll show it again as my last slide. Here are my disclosures, including prior NIH and foundation funding, and I serve on several editorial boards. Okay. As we think about this intersection of neurology and psychiatry, I want to introduce the name Stanley Cobb, who is a neurologist and established the first department of psychiatry at the Massachusetts General Hospital, one of the two hospitals I work at. And here's a quote: "There is no problem of mind versus body because biologically no such dichotomy can be made. The dichotomy is an artifact. There is no truth to it. And the discussion has no place in science in 1943. Really forward thinking, right? Showing the inherent interconnection between brain, mind, and body, right? But I would argue that in 2025, this vision has yet to be fully realized. So I suggest we're going back to the future, but also with some adjunctive improvements. Here's what I'm hoping to cover today. And so we'll start with, what is this entity of functional neurological disorder, and why are we having a grand rounds on it? First, we can think about subtype. So I will use the abbreviation F&D to stand for functional neurological disorder, the overarching category. And we can think about various subtypes of this, including functional motor disorder, synonymous with functional movement disorder. That label from functional movement disorder to functional motor disorder is a bit of a transition. It's in part to suggest that that subtype includes hypokinetic movements, hyperkinetic movements, as well as functional limb weakness, inclusive of all of it. We have functional seizures, also known as dissociative seizures, and many other terms. Functional speech as a third subtype. I've also argued, might functional speech, frankly, be a variant of functional motor disorder? More to discuss down the road. There's a newly operationalized term of functional cognitive disorder that we'll get to towards the end. And then functional sensory deficits, as well as operationalized variants of functional dizziness, in particular, persistent postural perceptual dizziness. I'm going to focus on the first four of these subtypes. And here's a really important disclaimer, which is that mixed symptoms are common. In fact, we could argue functional neurological disorder with mixed symptoms likely should be in that subtype list. And this is based on the notion, for example, that it's well known patients can present with functional seizures with or without other concurrent functional neurologic symptoms. And over the natural history of their symptoms, they can develop new symptoms. I also see this, interestingly enough, when patients are participating in the therapeutic journey, where they will largely present with functional seizures up front, these major events. As they get better, they're now having more minor events. Those minor events are a functional stutter and a functional tremor. There is no change in awareness. What's happened there? Has the diagnosis changed? Is it the same condition evolving? Is it the same condition evolving in that case scenario and potentially on the road to recovery? A lot to think about. In our cohorts, 1 in 4 to up to 50% of patients have mixed symptoms. And this is well described at many various centers. Okay, the epidemiology of this. It is so wonderful that we are flagging this in a grand rounds at Cleveland Clinic. And we're doing this because this is prime time neurology and psychiatry in 2025. It's really important. We know that there's a literature to suggest that this is likely, in many clinical settings in the outpatient world, a top 5 reason to be referred to neurology. We also have more quantified epidemiology data where the prevalence of functional neurological disorder overall is estimated to be about 80 per 100,000 people. How does that rank into other conditions that are discussed in the lay public? MS, 30 per 100,000. ALS, below 10 per 100,000. Really puts things in perspective. See if my slide is stuck here for a moment, but hopefully I'll fix that very quickly. Sorry about that. Let's go back. All right, apologies, but I think the slides are back. And now, given that epidemiology, I think we also have to recognize the huge gap in healthcare investitures, in funding, in government funding applied to this patient population. So in 2025, my colleague Chris Stevens led an economic analysis paper published in Neurology, where he showed that in the emergency room and acute hospital setting, in 2019, adjusted for inflation, we're spending $2 billion in healthcare costs in patients with functional neurological disorder. That's up from $1.2 billion in 2017. And yet the proportion of government funding is minimal in F&D. And you can see that those ratios are much better proportioned. For example, epilepsy in the top bar. Okay, let's think now, having stated the problem, what is our updated assessment and treatment paradigm for functional seizures, functional movement disorder, mixed phenotypes? And let's bring a patient into the conversation. This is somebody who's been generous. They've provided consent for the display of these videos. They've also participated in our research, brain imaging based. And this event occurred in the setting of me greeting the patient when they were participating in a research follow-up visit. Over the course of 5 minutes, they were symptomatic and symptoms largely improved. And we used this opportunity to talk about symptoms, provide context, and have a few reflections of what's worked. This is also somebody very notably who has mixed symptoms. You'll see functional facial dystonia and functional speech difficulties. This patient has paroxysmal events, and at times the functional dystonia and functional speech precede functional seizures. At other instances, those same F&D symptoms precede whole body weakness, really talking about a range of mechanistic convergence that we see over and over again. Describe for me, what are you experiencing right now?
I think I'm emotional because my speech is off and my face is very hardly twisted.
Now, it was a rainy day in the city of Boston, and this individual was hurrying to get to the research visit. So I asked them a little bit about some context. What happened?
And the guy says, "This happened before." He says, "I don't have the name," like I'm lying. Anyway, before that happened, I had another incident. I went into the wrong door, and the door was open on the side. And the security said to me, "How did you get in here? Like I'm a criminal or something." I said, "Well, the door was open and I came in. I had to get out of the wet because it was so pouring out." And I think that could have escalated the FND episode because it stressed me out. And he says, "Oh no, go down this way." And it's okay because I think he saw maybe that I was upset.
Notice that phrase, "I had to get out of the wet," which also has you think about functional language disturbance. And so what's worked in the therapeutic journey? FND now.
I think I'm a professional. I understand how it ticks. I wish I could get rid of it. That would be the greatest thing, but it's something I have to live with. So I have to have my tools to make this not so severe and come out of it faster. Before, I couldn't come out of it faster because I really didn't know what to do. And the first thing people say, "Oh, don't talk, because it's going to get you more excitable and more nervous and do it." Actually, that's the total opposite. Talking helps to tell people and to understand what F&D is. And then the face starts to come back up and the face starts to relax.
Okay, so we'll put a lot of this in context over the next few slides. So here are the three components that I would argue relate to the neuropsychiatric assessment of a patient suspected of having functional neurological disorder. We want to confirm the diagnosis using a rule-in approach, including documentation of certain semiological features. And in functional seizures, we certainly have the role of adjunctive EEG data as well, but largely a rule-in approach. We want to remain vigilant for other neurologic comorbidities. I think this is important to state up front because having a functional neurological disorder, a defined entity, one that we can diagnose with clarity, doesn't preclude a diagnosis of chronic migraines, doesn't preclude, for example, diagnosis of concurrent epileptic seizures. 1 in 5 patients has functional seizures and epileptic seizures. There's a literature now to suggest in older patients, the onset of a functional movement disorder can at times be concurrent or precede the development of a frank Parkinsonian syndrome, such as Parkinson's disease. And then in the assessment, our job is not only to provide frank clarity on the diagnosis, but it's to perform the assessment so that we can guide treatment. That's, I think, actually the big complexity for those of us who might be more classically trained on the neurology side alone, which is how can we perform a biopsychosocial informed assessment? And in part, this is because in neurology, we're so used to a focus on pathophysiology, on localizing the lesion, on providing diagnostic clarity, and how that is going to define a clear treatment plan. But in functional neurological disorder, those connections are quite blurry, they're nuanced, and frequently need to be individualized. So this brings us to this notion of juxtaposing biomedicine, a singular focus on pathophysiology, versus keeping pathophysiology front and center, but having that be put in context, the biopsychosocial formulation. Very importantly, the biopsychosocial formulation was put forth in Science by George Engel, not a psychologist, not a psychiatrist, an internal medicine physician. I would argue in 2025, as we think about precision medicine and all the kinds of ways, for example, that we can be assisted by variables like AI, that the closest we can get to with a precision medicine approach is really through the lens of being biopsychosocial informed. And might, in fact, some of these technologies help us better quantify biopsychosocial complexity at the individual patient level. Okay, I could give a whole talk on how to perform the assessment in a biopsychosocial informed way. To cover a fair amount for this audience, I'm going to direct you to this article, which is really a bit of a how-to with really practical lessons for how to approach the social history and a focused psychiatric screen in this patient population. And I've written this article with several colleagues that I work with in the F&D unit. Now, given that the clinical history is non-specific for F&D, although it certainly can raise an index of suspicion, right? For example, in functional seizures, when you're gathering the details of their seizure history, and they tell you that they're in and out of events, right, that last 40 minutes, sometimes several hours, spontaneously resolving, full body shaking events where there's preserved consciousness in the context of full body shaking events. There are clearly historical clues that can raise an index of suspicion. But ultimately, we want objective data, including with those events. I want to see the events. Now, this is an astute audience, and so I'm going to cover the rule-in physical examination sides rather quickly, but there are many, with a number of excellent review articles in this space, including work from John Stone and Alan Carson. For functional limb weakness, the Hoover sign and hip abductor sign being some of the most well-characterized. In functional tremor, there's this notion of, can we show frank distractibility, typically with a competing motor movement? Let me give you a sense of this. You can see a rest and postural tremor in the individual's right hand. Soon they're going to engage in contralateral thigh tapping. And here is complete resolution of that postural tremor. That was a robust rule-in sign. I like to make that qualifying statement because sometimes trainees in particular are wondering, was there an element of variability, distractibility? Was there a positive Hoover sign? These sorts of things. That was, or that lack of clearly robust observation suggests keep an open mind, bring in a colleague, these sorts of things. But we see robust rule and signs in clinic every single week, frankly, every single day. Okay, here is a patient with a very prominent functional tremor, and we're also going to see elements of entrainment. So that high amplitude postural tremor,
79.
a cognitive distraction task, is not influencing the movements, but a competing motor task, finger tapping, is showing near complete resolution of that postural tremor. Now there's emphatic finger tapping, and you can see that some of the movements are actually time locked with the emphatic finger tapping. The fact that the rhythm of movements can be influenced by the pattern or pace of movements in a different body part is called entrainment. You can also see pauses in the movements with ballistic movements contralaterally. So many, many rule-in signs for a functional tremor in this one short video. Functional gait, excellent article by Mark Hallett and many astute colleagues in the movement disorder literature published in Neurology. I'll direct this audience there for many videos. But here's just one such example of motor inconsistency. A young person coming into clinic with knee buckling type gait. And yet you'll see that they're able to dance in the office without knee buckling. They're even able to hop on one foot and hop on the other. This is frank motor inconsistency. I also like to talk about the toolbox or toolkit that we carry as physicians. I'm obviously not asking patients to dance in the office very frequently, but when there's an index of suspicion for these kinds of things, we can be nuanced in the kinds of investigations that we perform.
Okay. Can you take another step? Okay. Now, do first position du rond de jambe. Okay, can you do en dedans?
You suspect that this individual
En
was
dedans.
a classically trained dancer, where you're also engaging an element of automaticity. And we'll come back to that for the therapeutic approach.
Hey, hop on one foot.
That's harder.
How about the other foot?
And that's Mark Hallett's voice in the background. Okay, functional dystonia. Here again, observation and certain semiological features of the pattern of dystonic movements allow us to make a diagnosis of functional dystonia versus other neurogenic forms. So, for example, fixed dystonic posturing with plantar flexion and inversion of the foot, as you see in the top portion of the slide, a typical pattern for fixed functional dystonia. In the earlier video, you saw patterns of functional facial dystonia, sometimes grossly mischaracterized as a facial droop, but it's actually a hyperactivation of the musculature on one side of their face. Functional tics, this came to the forefront during the pandemic, certainly characterized before the pandemic as well. Here, this is an interesting subgroup where clinical clues in terms of onset and trajectory are part of what we use to raise an index of suspicion for functional tics. For example, many neurogenic forms of tics occur in childhood. There's an evolution of symptoms from gradual to greater severity. And in functional tics, there was a later onset, adolescence, early in life, sudden, not a slow progression. The tic movements were florid, high amplitude movements, at times self-injurious. And you can look for other features such as variability and distractibility. But some of the tempo, also the more female to male predominance in functional tics, all of this allows us to frame it as functional tics versus other forms of tics. For the sake of time, I'm not going to share with you audio, but here are 3 subtypes of functional speech. New onset adult functional stutter. Okay, sudden onset foreign accent syndrome. Some of those cases have been framed as lesional post-stroke presentations and other presentations, but many, many cases of foreign accent syndrome are variants of functional speech, and then functional infantile speech as the third common variant. Functional seizures. This is a world-class epilepsy audience, and you are likely all very familiar with some of the semiological features that help us distinguish functional seizures from epileptic seizures. Tight eye closure at seizure onset. Those asynchronous movements at times with side-to-side head shaking, events stopping and starting. And I mentioned this notion of duration as well. Duration obviously is a complicated variable in the acute emergency setting, but when you're gathering historical data, notions of very prolonged events that spontaneously resolve really are helpful to provide an index of suspicion. Tongue biting, urinary incontinence, very importantly, non-specific, though the site of tongue biting likely has some specificity, including we all recognize that those large lateral tongue bites, very concerning for generalized tonic-clonic seizure. But when you ask about tongue biting more broadly, tip of the tongue type events, very common in functional seizures. Here is a typical case of functional seizures being characterized in the epilepsy monitoring unit. And this notion of capturing video and EEG concurrently in the context of appreciating a documented major motor event allows us to provide the highest level of certainty. That highest level of certainty is a documented functional seizure, and there are lower levels of certainty from clinically established to probable to possible. I'll direct you all to the LaFrance Epilepsia 2013 paper for those 4 levels of diagnostic certainty. But here we're making the highest level of certainty, documented functional seizures. Oops.
That's it. Good, good. Keep blowing. It's definitely going to come again. Applesauce.
Those bicycle movements might raise some concern for frontal lobe epilepsy, but you can see how this evolves.
Eyes are wide open. I don't want you to deep breathe like that. Just relax.
Now the movements are more tremulous. The bicycle movements return, but at a
Lift your
slower
right
tempo.
leg up in the air.
So stopping and starting. Variable
Lift your
synchrony.
left arm up in the air. Point to the ceiling.
And apart from muscle artifact, this patient's EEG before, during, and after the event lacked any epileptiform activity. Okay, let's think now about treatment considerations. And let's frame the initial steps of treatment as including everything we just talked about so far. Right? So the assessment is where treatment begins. Really important, including how we engage the patient, how we frame, our understanding of some conditions living at the intersection of neurology and psychiatry. And obviously, we need to obtain variables in a biopsychosocial informed way, because if we lack that information, we can't use it to guide treatment. You've done your assessment. You've appreciated rule-in signs. You've looked at your adjunctive diagnostic markers. All of it points towards a functional movement disorder or functional seizures. None of it points to a major concern for another neurologic comorbidity such as epileptic seizures or Parkinson's disease. And you're at this stage. How do you talk to patients about this? So again, if I wear my neurology hat, one of the things that comes up often is this notion of, good news, right? Your brain waves on EEG looked healthy. Good news, your structure MRI looked good. Your EMG nerve conduction study looked reassuring. This good news approach is invalidating. This good news approach is not meeting the patient where they're at, which is they're really struggling and they're confused about what's going on with their symptoms. So we want to think about maybe the good news being that there's treatment options, but keep that off to the side And you really want to focus with clarity and transparency about what you think is going on. So Mr. or Mrs. Jones, based on your history and very importantly, based on your exam, including, for example, I showed you that tremor that you have when your hand is straight out, we were able to have it go away, right? And go away completely when I had you do other tasks. Or Mr. and Mrs. Jones, it was super helpful and very helpful to get that video EEG data, where we could see, for example, the exact patterns of your events. Eyes shut really tight in the beginning. The movements came, they would stop, they would start. They were quite a bit variable. We even captured multiple events, a little bit of variability between those events, but that's what we see with functional seizures. And all of those events are highly consistent with a type of seizure. We call that functional seizures, right? So based on a rule and approach, I oftentimes will frame things as overarchingly part of a functional neurological disorder, real, common, brain-based. They are not crazy. They are not making up their symptoms. And functional seizures and the whole category of functional neurological disorder represents a condition that lives in between neurology and psychiatry. Have you heard about functional neurological disorder before? Many patients haven't. And that's where focus on information such as neurosymptoms.org and even playing some of the videos in clinic or when I'm on the wards, I will have patients look up neurosymptoms.org on their smartphone. And I will sometimes also encourage them when I walk out of the room to play some of those videos and learn more about this condition. The other pitfall is, what is happening, doctor, right? Focus on the diagnostic assessment and giving it a clear term. Why do I have this is a major pitfall. The why is complicated, the why is nuanced, the why is individualized, okay? And patients learn the why for themselves over the course of treatment. Try to focus on the what up front, try to defer a bit the why through the natural course of treatment. And there are ways to get to the why a little bit, including that patients who have events that come and go, I will frame these events as a form of brain, mind, body overload. The reason that I frame events that come and go as a form of brain, mind, body overload, rather than these conceptual frameworks of hardware healthy, software crashing, right? Well, my software is crashing, doctor. What can we do about it? Versus brain, mind, body overload, we can talk about, are there medical factors? Are there social factors? Are there life factors? Are there mental health factors that might be contributing to overload? And if we can identify those overload factors, then we can develop with precision a patient-centered treatment plan. This non-psychiatric language of brain, mind, body overload, I find in general is well received by patients and families. I do change and alter my analogy based on who's in front of me in clinic. Okay, so you communicate the diagnosis, you name it, real, common, treatable. You provide some focused education, including maybe playing a video or two from neurosymptoms.org. And you need to ask yourself, how is this going in terms of your communication of the diagnosis, right? Are they dissociating in front of you? Are they having another functional seizure? Are they, saying, doctor, I think you're being very thoughtful, but I got to tell you, this is all a nice way of saying it's all in my head and that I'm making up my symptoms, right? All of these kinds of instances signpost the patient is not ready for the next treatment discussion. So one of the big errors people make is going right from diagnosis to treatment. Let me refer you to my colleague X. Let me refer to you my colleague Y. They're not ready to engage in good treatment. Hold off on those referrals. See if you can encourage an element of exploration, curiosity, more education. If they're in the inpatient setting, I'll come back tomorrow and we can talk more about this. If they're in the outpatient setting, why don't we schedule a follow-up visit after you spend some time looking over the materials and we can talk more about your impressions and thoughts. Okay, so we need an element of buy-in, an element of receptiveness before we transition to evidence-based treatments. other thing is, what did you learn from your formulation? You know, for example, there's a literature of intellectual disability and functional seizures. Is this one of those cases of later life Parkinson's disease and comorbid functional movement disorder? Is this somebody who's been in an electric wheelchair for 10 years, but has major deconditioning, where you want to involve physiatry up front? Had they have functional fixed dystonia for years? Are you worried that that functional fixed dystonia has evolved into contractures? Again, really good reasons to bring in physiatry early up front. Is this a case of an individual who's high functioning, who has some perfectionistic traits, who's minimized the impact of anxiety, depression, and their main playbook is to push through, right? That's one variant that's at risk for brain, mind, body problems. Is this somebody who has major mental health concerns, whose post-traumatic stress disorder and flashbacks actually overlap with their functional seizures? And there's too numerous to count other variants. So putting the patient's diagnosis in context. This is what I mean by biopsychosocial formulation. And this can be done in team-based approach, including patients being assessed by individuals with neurologic expertise and mental health expertise. Okay. The assessment as treatment. Communicating the diagnosis and engaging the patient. Critical for treatment. Thinking about biopsychosocial informed points that might suggest you might want to deviate from some fairly evidence-based pathways for F&D because, for example, this is a case that has borderline personality disorder, prominent self-injurious behavior, functional seizures, and you're going to triage dialectical behavioral therapy as really frontline treatment for such a given individual. Right. We can think about treatment in this pronged approach of skills-based psychotherapy being critical, and for patients with prominent motor and movement symptoms, roles for physical rehabilitation. I'll also talk about roles for occupational therapy for patients with paroxysmal events, particularly with sensory triggers. So there's been a sea change in the therapeutic playbook for F&D in the past several decades. A number of different workbooks, and a growing number of clinical trials. This is the self-guided cognitive behavioral therapy workbook that was piloted in the Neurology clinical trial in 2011. That workbook is called Overcoming Functional Neurologic Symptoms, a 5-Area Approach. For the neurology audience that thinks a little bit less about CBT, right, this is exploring relationships between F&D symptoms, thoughts, behaviors, emotions, and life stuff. This language of trying to explore one's personal equation for the development and maintenance of their functional neurologic symptoms. So let's see, are we stuck again? All right, let's try one more time. All right, a couple slides advanced, so I'm going back. Apologies. All right. So in these domains, right, there are a range of unhelpful patterns, unhelpful illness beliefs, unhelpful behaviors. For example, go, go, go until you crash, something called boom and bust, prominent avoidance behavior or lack of assertiveness, a range of ways in which affective symptoms can amplify or trigger functional neurologic symptoms. And in addition to that personal equation, many of the skills-based psychotherapy approaches have an emphasis on identifying triggers, external factors that might, or internal factors, frankly, external or internal factors that might bring about an event, and then bodily warning signs. Do you have, for example, a sense that you feel a little bit disconnected, that your heart's racing, that you're searching more for words, that you become nauseous. Some of the autonomic symptoms that we might characterize as associated with panic attacks, those are frequently warning signs for functional seizures. Okay, there are workbooks published by our friend and colleague Kirk LaFrance in the functional seizure domain. There are also more workbooks coming from his group in terms of specific workbooks for functional movement disorder and functional cognitive. In the functional seizure space, many of you are likely aware that the seminal CODES trial was published in Lancet Psychiatry by Laura Goldstein and colleagues in 2022. This was a large-scale work. 186 patients received standard medical care plus cognitive behavioral therapy. The variant of cognitive behavioral therapy focuses on a fear avoidance model, triggering and perpetuating functional seizures versus standard medical care alone. Very interesting results. The primary endpoint, monthly seizure frequency at 12 months. No difference between the groups, although each group, as you can see in the lower portion of the slide, did somewhat improve. Yet the secondary outcome measures overwhelmingly favored skills-based psychotherapy. This also suggests, maybe a one-size-fits-all skills-based psychotherapy approach to functional neurological disorder needs to be more nuanced. And the nuanced interplay being, what's the formulation that goes with the given diagnosis? We talked about such a biopsychosocial informed approach in a New England Journal CPC that was specifically a case of functional seizures, discussing its journey from the emergency room to a documented diagnosis to a treatment that largely emphasized the clear and direct overlap, in this case, between post-traumatic stress disorder, dissociation, and functional seizures. Okay. Being mindful of time here, I'm going to cover just briefly physical rehabilitation, and I may leave functional cognitive out so we can have a conversation. But there are now consensus recommendations for the use of physical therapy, occupational therapy, and speech and language treatment in this patient population. There is an element of motor retraining, including using distraction and dual task performance to allow normal movements to reemerge. Here, I'm bringing you now to the physical therapy suite. These videos are with consent and provided by our physical therapist, Julie Maggio. Here is a case of prominent functional motor disorder. You can see some inward turning of the feet, a wide base gait, real difficulties with postural control, high degree of stiffness.
Which was kind of like why I gravitated toward her.
Obviously, the more rule-in signs for a functional motor disorder would be with patient engagement, which you're not seeing on video. And now, watch what you see when we're introducing kicking a soccer ball.
Okay. Okay. You ready? Yep.
So again, it's an external focus of attention.
Powerful legs.
That second kick there, quite nice and fluid. Patient's able to demonstrate a fair bit of improvement in postural control. You can even see that the base is more narrow-based. Okay, for occupational therapy, there is a range of interventions that occupational therapists can employ. I will say that I have the pleasure of working with two astute occupational therapists, Jessica Ranford and Julie McLean, and these colleagues have taught me about an occupational therapy playbook for assessing sensory processing difficulties, including the notions that bright lights, loud noises, body pain can trigger or worsen functional neurologic symptoms. There's a literature for sensory processing difficulties in autism spectrum disorder, in affective disorders, in chronic pain. And when we started referring patients for occupational therapy who had a functional neurological disorder, this is what our occupational therapists started doing. I went back to them and I said, oh my gosh, what exactly is this playbook? How are you assessing this? Let's study these phenomena and let's document your therapeutic playbook. So we've actually had a discovery sample and a replication sample where we showed, in comparison to normative data, patients with F&D are much more sensory avoiding and sensory sensitive, among other features of sensory processing, than the average individual. And my colleagues have really put together a sensory diet based that's personalized based on one sensory profile. What this means is, are there regular sensory tasks that one can engage in to maintain a just right level of balance and arousal? Not too hyper aroused and not too under aroused, but appropriately engaged in the task at hand. And can we identify interventions that, if you're hyper aroused, might bring you down a bit, and if you're totally disconnected, might increase your engagement? This is what goes into a sensory diet, including sensory meals, regular strategies that you might use, such as using a weighted blanket at night, and PRN sensory snacks for as needed. And by the way, because this comes up with questions, one needs to be adaptive with this, right? We're looking for adaptive interventions, not maladaptive interventions. An example of a maladaptive intervention would be extreme sensory sensitivity. So now you come in with dark glasses and earplugs and a hat, and you have to have the lights off in the room. These are not adaptive sensory strategies. So guiding the patient, there's this whole literature, there's our individual differences in sensory processing, and there are things we can do about it. I also find that sensory sensitivities are quite common in the paroxysmal F&D group, both for functional seizures and functional motor presentations. I'm looking at time, and I'm going to just flag for you all that there is a new entity of functional cognitive disorders. I wanted to put a spotlight on this because many patients with functional seizures have cognitive complaints. Many patients with functional seizures have prominent dissociation. And you can ask yourself, what are the connections between those cognitive complaints, their element of dissociation, that element of brain fog, and does this overlap to some degree with functional cognitive presentations? This feature of internal inconsistency in one's cognitive performance. There are now checklists, or a checklist, that one can use in the clinic, the functional cognitive disorder checklist, published in the BMJ Neurology Open. It's pilot work, meaning it needs to be prospectively replicated, but it did involve about 45 cognitive experts across 2 separate papers to develop this checklist. And now Alan Carson and colleagues are prospectively validating this in cohorts. My last slide, I bring you to this tree that I showed in the first slide. And this is a reference to Charcot's tree. Charcot and colleagues in the Salpêtrière had neurologists and psychiatrists and other clinicians working side by side. And some of Charcot's writings talks about the neurologic tree. And in the neurologic tree, he puts side by side what we now frame as neurologic conditions and mental health conditions, part of the same tree. Maybe slightly different branches, and maybe some branches entirely overlapping, but part of the same tree. And this is here where I think across the clinical neurosciences and across the rehabilitation neurosciences, we need this kind of tree. And we need this kind of tree deployed with precision in the outpatient setting and in the inpatient setting. It's also this framework, I would argue, that allows research, mechanistic and therapeutic, to be biopsychosocial informed and interdisciplinary. I'll leave this CME credit up for a moment. And here is my contact information, including my email, in case we don't get to all of your questions. Thank you very much. Grateful for the invitation.
Dr. Perez, this is fantastic. And I think that we are getting some messages in the chat saying the same thing. I am so glad to see that there is an opportunity for physical therapy for these patients. When I did my pediatric neurology training at the University of Michigan, the Department of Physical Therapy was always very receptive to receive these patients. And we could see that introducing that element of rehabilitation, it will change the buy-in for the parents in a dramatic way. And oftentimes, by the time the kids left the hospital, their symptoms were almost resolved. So I was wondering why this approach that was so obvious, and I mean, this is 20 years ago, hasn't come to the treatment of functional neurological disorders. So I was very delighted to see what you are showing us. Do you happen to have any data on kids? On how this approach?
Yeah, such great question. So let me take a couple of those because very rich, very astute too. So one, what's interesting is I have found great pleasure and intellectual exchange in working with my physical therapy, occupational therapy, and speech and language colleagues. I really encourage a horizontal structure of communication and exchange. It's been very energizing. You can see, for example, many of those colleagues are now part of my research group. They're driving as senior and first author research. And what I hear from them, including senior people who have mentored more junior people now, is said, look, we've been seeing functional movement disorder for decades. The problem is that our physician colleagues have not been documenting clearly in the notes what's happening. They've not been providing education on what their opinion medically and neurologically is of what's going on. So the physical therapist is trying to do strategies, but the patient's quite a bit confused and misguided in where things are going. So good cohesion, right, with all, in the messaging, the diagnosis, the communication, shared language, brain retraining, right? This notion of we're engaging in physical therapy or occupational therapy for brain retraining. And then very importantly, a powerful form of brain retraining is psychotherapy, skills-based psychotherapy. So now you bring in this language of brain retraining. It's psychological, it's physical, it's rehabilitative. And I share with people that the distinctions between neurology and psychiatry are artificial, they're societal. There are various diagnostic manuals. Here's the problem. Our brain did not get that memo. The brain doesn't separate into neurologic circuits and psychiatric circuits. And some circuits are exactly the kinds of circuits that are so important for higher order neurologic and psychological considerations. Kids, thank you for flagging this. So Kasia Kuzlatska in Australia is a child and adolescent psychiatrist. If someone's very interested in this space, you can email me. She has 2 free textbooks. One textbook is on the treatment of functional seizures. And so it's very, very good and publicly available. And long story short is the key with kids is they very often have mixed symptoms. The family and school environment are critical to the formulation. You want to raise an index of suspicion for brain, mind, body symptoms early. You want to be thoughtful, do an appropriate workup, but do not delay introducing the possibility of brain, mind, body until you've done like $1 million workup and they've seen 20 people. And, and because the medicalization of those problems makes those kinds of cases really tough to go backwards. You introduce, you normalize, you suggest it could be relevant. We're going to be thoughtful of other possibilities. You provide non-dualistic framings, and then kids in general can do quite well. And then there's a chronic population that's more complicated. But the bottom line is similar approach to kids, family and school, so critical, including buy-in from parents, very important.
Yeah, yeah. I wonder is how the parents get integrated into this therapy. Is one of the things of my interest to hear about. Absolutely. Thank you so much. You have Dr. Paul Ford.
Hi, I'm a medical ethicist that's embedded in the Neurological Institute.
Excellent.
Fantastic set of reflections. I so appreciate your comments. Treating patients in respectful communication ways is so important. Do you have some reflections on when you have an FND diagnosis and you start somebody on a plan that could be effective, of how we can help system-wide when they go to the emergency room to help them avoid serious, dangerous interventions that ED physicians are tend to do, intubation, epilepsy medicines, others that are unneeded and put them unnecessarily at risk when you've identified that there's a different kind of pathway they need to go along.
Yeah, great question. This was rich. I'll be succinct, but there's probably more to cover than what I'm going to say. I think the first thing is, so if I talk about the naturalistic journey of how our clinical program developed, right? I was in a room by myself, when this all started. And what I did was offer the myself up for talks. I spoke to the rehabilitation group, PTOT speech. That was easy. People raised their hand and said, I see this. I see this. Oh, you want to be a partner? Wonderful. The psychiatrists and behavioral medicine and psychology folks and neuropsychology folks, very interesting dynamic there. I think the most empowering thing was to share with them that a multifaceted skills-based psychotherapy playbook, one that they're using in anxiety disorders and trauma-related disorders, that in borderline personality disorder, that this is kind of the playbook for functional seizures. And then I did the same thing with talks in the emergency room. And I think actually there it's the education. This is a real entity. It's targeting the stigma. It's teaching people, look for those rule-in signs. Look in the chart. And the chart isn't that functional neurological disorder does not mean faking. Functional neurological disorder does not mean malingering. So helping a little bit the language is important. We need clarity of documentation. So with clarity of documentation in the emergency room, you open up the notes and now they see, this is somebody who has a functional neurological disorder. They've been worked up appropriately. And you can gather that history very quickly. Those are some bits. Then two other things. I think educating the patient and exploring, why are you going to the emergency room? What are you hoping for? Right? It's akin to, for example, somebody having a really bad panic attack. They don't know what to do. They're overwhelmed. They think they're dying. But the emergency room is not the place to get care for panic attacks. So understanding the cycle of validating, you are overwhelmed. It's unclear what to do. You're at your wit's end. But none of that's going to get addressed by going to the emergency room. Also, real buy-in from the patient and the family that we're not missing something. I think that's really important to resolve. Sometimes everyone's on the same page, but then they're going to lots of community hospitals, and that's where also providing them some kind of writing. This patient is, receives care at the Cleveland Clinic, has a diagnosis of functional seizures. It's a documented diagnosis. It presents with shaking and difficulty speaking. It spontaneously resolves on its own, generally does not need medical intervention, recommends supportive care, and making sure that there's a good hemodynamic and respiratory stability, but otherwise. So this kind of thing can help. All of that coming together has reduced the issues. But what I have found the biggest challenge is we've done this once and we've done this twice and we've done this maybe 3 times, but there's so much turnover that you have to keep educating the systems. True for our own system and maybe other systems too. That's why I do lots of writing, because I also find that, I tell people this when that I wrote an article a while back with some colleagues. So you've made a diagnosis of functional neurological disorder, now what? And we wrote that article because everyone was knocking on my door. Hey, I made that diagnosis that you specialize in. Can I send it to you? But there's way too many patients. And so all of this comes together, I think, to tackle some of the issues, including iatrogenic considerations.
Thank you. I appreciate that. And I do see a comment in the chat from one of our wonderful community people who I'll let Dr. Pestana Knight talk about that.
Yes, I wonder, Lee, if you want to unmute yourself and make the comment directly to Dr. Perez. Are you able to unmute yourself? And we have, okay, so Lee Goldie, here she comes. Can you unmute yourself?
Yes,
Lee?
now I can do it. Thank you. Can you hear me?
Yes.
Okay. Yeah, thank you so much for this amazing talk. Anyone dealing with FND or non-epileptic seizures is kind of left to on their own to fend for themselves after diagnosis in most cases. So everything that you are discussing was absolutely amazing. I'm the founder and executive director of Empowering Epilepsy, which is a nonprofit organization to help people live well with epilepsy and seizures outside of the doctor's office. All of you are part of an oasis in the desert that we get to go to get diagnosed. But once we leave that oasis, we are living with this all by ourselves, whether it be epileptic or non-epileptic seizures. We have inserts specifically for non-epileptic seizures written by Kurt LaFrance, and another one that's currently in the editing stage right now. But what we want to do is better educate them. So if you can share that information, any of you can share that information with your patients about our patient education program, that's amazing, because we can help them better document what they're experiencing so that they can give you, all of you, the data that you need to make a more accurate diagnosis and treatment plans sooner. Anything that we can do to help these patients, because they are left to fend for themselves in most cases.
Yeah, excellent comments. Thank you. I completely agree.
Thank you, Lee. We have also Chin Yu. Chin, if you could unmute yourself, please, and ask your question.
Thank you. Thank you so much, Dr. Pestana. And hi, Dr. Perez. Such a wonderful presentation. Just really appreciate just your wonderful work in this field and really a guiding light. I'm a movement disorder neurologist, and I run the FMD program here with my wonderful colleague in psychology and rehabilitation. I have a question, just curious to your approach in kind of answering the prognostic question, when patient come, and if you would approach differently, when a patient maybe is recently diagnosed with recently developed symptom versus someone has been undergoing this for 10 years and plus, and how would you approach the prognostic question differently or similarly?
Yeah, great question. I would actually say I approach it similarly. So here are some of the thoughts there. I share with patients that while I don't have my crystal ball, that I do have the opportunity every week to see patients get better. And that as a field, we're still learning about which patients have the most positive results and which patients get a fair bit stuck. But many, many patients get better. And so let's continue to think about, actually, can we connect you to good treatment? Can we explore and potentially also address any factors that might be slowing down your recovery? And let's see how things go. And I will share with patients when I see them longitudinally, as I monitor their progression, a couple things. Sometimes symptoms get worse before they get better. This is something to flag up front, in part because that avoidance, right? So a case of a functional movement disorder, maybe with prominent pain, where they engage in a bit of a walk. They have lots of shaking and lots of body pain, and now they're restricting their movements. They're not leaving the house. In fact, now they're using a wheelchair. And every time they try to take a walk around the block, they become incapacitated for several days, right? So that's that fear avoidance pattern. And ultimately, that needs to be tackled in part by slowly engaging in motor retraining. So sometimes symptoms get worse before they get better. 2 is your formulation can identify perpetuating factors. I think this is really important because when patients are in treatment longitudinally, you want to ask yourself, are there identifiable perpetuating factors? And are those perpetuating factors well treated, well managed? You know, are they doing poorly from their functional movement disorder, but every other aspect of what you identify as a perpetuating factor seems to be going well? Or are they doing poorly, but there are obvious perpetuating factors that are under-addressed? And sometimes the perpetuating factors are hard to address quickly. Homelessness, right? Major adverse life experiences, chronic post-traumatic stress disorder, severe with prominent dissociation. The chronic PTSD is active. The major depression is active. There are medication approaches, skills-based psychotherapy approaches. It's interacting with their F&D symptoms. And you're seeing them for a year, and their PTSD is still really significant. That is a case where ultimately prognosis is guarded, but there isn't confusion about the formulation and why they might be struggling. So I make a distinction between clinical trajectories, and then also if they're doing well, everyone's pleased. And if they're not doing well, are there perpetuating factors that are recognizable that need more attention? If so, continue and maybe double down and think about new strategies. And if they are not identifiable and they're not doing well, then that's also where I say revisit the diagnosis, make sure there aren't any other comorbidities or other considerations that maybe are under-recognized or are being under-addressed. You know, for example, is anyone targeting their chronic pain? Or is it somebody with autism spectrum disorder, where it's really struggling with chronic alexithymia and interpersonal exchange? So these are chronic factors that might be contributing to overload. So again, all of this is a multiplicity of saying, I'm hopeful. I want to encourage an element of hope, of hopefulness. I do not have any guarantees, and let's walk this journey together.
Thank you so much.
This is fantastic, fantastic. I think that we're going to have you soon again because there are many more questions. There are a number of people in the chat asking for you to show the slides again with the FND3.
If someone can email me, I'm very happy to make sure that a PDF of my slides is distributed to you all.
Yes.
So if you don't have that already, and I did make some very last minute updates, the tree I put in 2 spots as opposed to 1, that sort of thing. I'm very happy to give you an updated copy.
Yes. Also, our lectures are available. If any of you want to watch it later, this is completely possible. Okay. So I think that is 9:11 a.m. already. I want to thank you, Dr. Perez, for this insightful lecture. I certainly learned a lot. I think it was very useful for our residents and fellows also to see what maneuvers they can use to make clear diagnosis. You are already getting a lot of applause. And I want to tell you that our audience today covered North America all the way to South America and all the way to China.
Wow.
That is how much interest there is in this talk. Thank you.
Thank you. It was an honor. I'm starting my morning very energized. Until next time, please do email me. I'd be happy to chat some more. Thanks,
Absolutely.
everybody.
Thank you.